And when I was preparing for this talk, I came across this picture and I thought, that's tender. That's gotta be people living their healthiest and best lives in their senior years, and we want to keep them there. But it turns out, if we can have the next slide, that healthy aging is a very serious matter. It comes with a lot of work in order to stay well, and that's what I wanted to talk to you about. So next slide, please. So the World Health Organization defines healthy aging as a process of developing and maintaining the functional ability that enables well-being in older age. So it's a process, it's dynamic, it changes, and there's intrinsic capacity that has to do with the older adult, and then there's a functional ability that has to do with the environment that that older adult interacts with. And both tend to decline with increasing age, but it doesn't have to be. And life choices and interventions at different points in the life course will determine the path or the trajectory of that aging journey. And then there's a concept of heterogeneity of aging, and that's saying that we don't all age the same, and chronological age is not a real indication of how well a person is aging. So we need to look at another way of looking at how well the person is aging, and that's where I've looked into frailty. And the next slide. So again, when we talk about that healthy aging journey, there's the intrinsic capacity, that's the composite of everything that the person has physically and mentally that they bring to bear as they're aging. And then their environment can offer resources and barriers to living a full life. And then there's the functional capacity. And we talk about functional capacity in terms of physical function. A person declining in mobility is a loss in function. But this is talking about the combination of the individual and their environment and that interaction that allows them to be their best, to live their best functional life. So these are the two definitions that you can keep in mind as we go through. And then the next slide. So when we look at frailty, we know that age does not equal frailty. And this is my favorite picture that Annette found, I think, years ago when we used to work together. And then the next slide shows that there's this heterogeneity of aging. So you can be 80 and you can have some decline in function and you can have some frailty. Or the next slide shows a person who doesn't have that decline because they've actually kept a really active lifestyle and they're running an under 4-hour marathon, which is better than a lot of us can do. So the next slide again. So there is a way of measuring frailty. So if we're not going to use age as a measure, so how do we measure how a person is aging? So there's ways of assessing frailty, and that's what we talk about when we do an assessment. So it used to be that we had physical frailty measures. That was a Fried's frailty phenotype. So there is a slowing of the gait, there is early fatigue, weakness, loss of muscle strength, easy exhaustion, low physical activity. These are the physical traits that you see in a person as they get older. And that used to be our definition of frailty for a long, long time. But then came the understanding of the clinical frailty scale being a reflection of a person's function. So can they function? Are they able to exercise and do all the things in their community that they want to? Or are they starting to get slowed up? They might need to have walking aids. They might depend on others to get around. Or they start needing help inside the home. And that's the functional assessment for frailty. And then more recently, we talk about frailty index. And the understanding that as you get older, you start accumulating little health deficits, things that go wrong with your body. And the more you have of them, the more frail you can become. But the good news is you can actually reverse some of those things and actually prevent and delay frailty. And that's the exciting piece. And the next slide, please. So the clinical frailty scale, you could probably just do this on your own by looking at this. If you are lucky enough to be very fit, you're a scale of 1, you're exercising a lot on your own, very independent. You can get to 3, where you're starting to have a little bit of chronic condition maybe, but still managing well. And then 4 is when you're starting to get slowed up, where you start to live with very mild frailty, where you start to get need a little bit of help to get around. And then 5 is where we actually start seeing people that need help to get to places, needing to get help getting groceries, doing their banking, some of those activities outside the home. And then the health authority looks after people with a scale of 6, where they start needing help inside the home, where they have needs like bathing needs and light housekeeping needs inside the home. Those are sort of more advanced to moderate scale, and then we end up with people that are getting further into the frailty and palliative care and end-of-life care. And we also acknowledge people with cognitive decline, and you know that the people with dementia, the numbers are increasing. And as you have mild, moderate, and severe dementia, we correlate that with our frailty clinical scale as well to mild, moderate, and severe frailty and dementia. So the next slide then. So this is the idea of the accumulation of health deficits. And so it's really important to identify early as possible when a person starts accumulating these health problems. And it may be little things like blood pressure going up, or it could be significant things like your hearing is starting to go, your vision is starting to go. And all of these accumulate at a rate of 4.5% increase of things going wrong with you every year. And every 15 years, you double the number of things going wrong with you. So between the age of 75 and 90, you could double the number of things going wrong with you. So you better start with a very small number of things wrong with you to start with. So you don't want to be doubling a lot of them. And so the opportunity that we talk about is before you get to be too advanced in your frailty. So starting really at age 60 to 75, we know that there's going to be a doubling of things going wrong with you. And between 75 and 90, that's probably the last doubling of things, and beyond the age of 90, it becomes really difficult to reverse those things that are going wrong with you. But when you can do a fulsome assessment of an individual as they're getting older, you can identify those things that can be reversed. Like hearing, we can actually intervene and do something about that, because if you don't, it will affect everything in their lives. And vision, of course, and other things that we can assess for. And then, so that reversing of components of frailty is how we're going to delay frailty, prevent, and reduce frailty. Next slide, please. So this is the comprehensive geriatric assessment tool that we've developed. And this was originally developed by Dr. Ken Rockwood out of Dalhousie, but it was a paper-based form. And the work that we did, that Annette and I did together, was to turn this into an electronic form so that it's available in physicians' offices in their electronic medical records. They can actually click through all of those fields, and then it will generate a frailty index, looking at number of things that are wrong with you compared to all the things that we asked. So the frailty index is a very sensitive measure of a level of frailty, and you can do interventions to see if whatever you introduce is actually going to improve the frailty index, and over a period of time you can actually see that number changing. And the next slide, please. And then the Canadian Coalition for Seniors in Mental Health, CCSMH, just put out a clinical guideline for loneliness and social isolation just in the last month or so. And this is recommending that in order to prevent loneliness and isolation, you need to do a fulsome intake assessment as well. So this is very similar to that comprehensive geriatric assessment. You need to really understand the medical history, the social history, the mental health, the memory, the cognition, and screening for environmental problems like finances, recent life events, lifestyle factors, insight and motivation to change, because all of these things will lead to, if there are problems there, it could lead to frailty and certainly to social isolation and loneliness, which is so detrimental for health. And the next slide, please. So recognizing frailty, frailty may stem from just age-related decline across multiple organ systems. It might be that the person is suffering from chronic diseases or having to take lots of medications. There's decline in function, their mobility. It may be social factors like poverty and isolation, poor nutrition, and psychiatric mental health associated issues at all. So frailty is not a common or not a single system disease. It's across the whole spectrum of things that can go wrong, and so we have to intervene in a very creative way, addressing what is the problem and helping the individual to get over them. So the next slide. So when we measure the frailty index, we're looking at the cumulative effect of accumulating all those deficits, and that the frailty index has been shown to actually predict survival. It actually tells you how long you might live. It actually tells you when you might need to go into a long-term care facility. So it's a really sensitive and important indicator for frailty. And then we talked about the doubling of the health deficits. And it turns out that those that are socially vulnerable, those that have issues with finances, isolation, they suffer more at any level of frailty. And that social isolation can lead to frailty as well. So the next slide, please. So social isolation is really a critical thing that we need to raise the profile and talk about and really address in communities like yours and anywhere actually where we have older adults. These are numbers that come out from longitudinal studies of seniors. There's an increase of 50% in developing dementia when you're socially isolated, 45% increase of premature death, 32% increase of stroke, etc. So really detrimental to your health, and we do need to raise the profile of social isolation. And social isolation talks about the quantity of relationships and quantity of contacts with the outside world, and loneliness talks about the quality of those interactions and the quality of relationships that you have in your life. So you could have just a few interactions, but if they're high quality, then you don't sense the loneliness as you do if you have poor quality of interactions. So the next slide then. Instead of waiting for somebody to be socially isolated, we can look for risk factors. So you can sense people in the community, your neighbors, your friends who might have these risk factors, and then become aware of potential decline in their health and try and intervene as much as possible. So those that are living alone, or if they've had a major life transition, such as loss of a partner, if they've lost their job, they have financial limitations, low access to transportation, if they're caregiving for somebody and they themselves are feeling stressed, they certainly are at risk for social isolation. Living in rural settings, if they've been relocating because they want to be near their children, they've lost all their social contacts, they're at risk as well. Small social network, minority groups. Those are people that are super at risk for social isolation and loneliness. And then health risks too, if people have recently had loss of mobility because of perhaps a fall, or they've had problems with their backs, they're not getting around as well, that's going to affect their ability to connect with their social network. And disabilities, health effects that come along, and certainly cognitive vulnerabilities. If they're starting to have memory loss, they're at high risk as well. And depression and compromised self-efficacy, anything that leads to those in the world of the health risk factors, we know it will lead to social isolation and loneliness as well. And the next slide. So the risk of social isolation, I talked about the big four. The three that we need to keep in mind, the 3 Ds. The dementia is really high, depression, and death. So the 3 Ds are easy to remember. You don't want that. You don't want that for anybody that you love. You don't want that for your neighbors. And then you actually have, decreased quality of life, of course. And then you have generally poor health and increased number of falls even. So just being isolated increases your risk of falls. And increased risk of falls leads to potential death, of course, and then decline in function, potential need for hospitalization, further decline in function, potential need for long-term care admission. So all of those things are nasty, nasty things that social isolation can lead to. So that's what I've been fighting for a number of years now. Okay, so next slide. And scoring loneliness is interesting. There are a couple of scales that we've looked at. And this one is really good because it's just one single question you can ask. During the past week, how often have you felt lonely? And you score this, rarely or none, if less than 1 day a week, or all the way to almost all the time, 5 to 7 days a week. And if you're scoring not lonely or rarely none, then that's you're not lonely. But if you're scoring sometimes or greater, so sometimes it's 1 to 2 days or greater, then you are lonely. So being lonely then is that detrimental effect to your health that can lead to the health decline. So it's a good question to ask yourself or have your loved ones, older people that you care for or interacting with, ask about themselves and see what you can do to improve that loneliness by just asking that one question. And the next slide. So after we do a fulsome assessment that we talked about, what follows is a care planning process. And this is done usually by either the nurse or the doctor that did the assessment or somebody else that did the assessment, looking at all of their medical history, their medication, etc. And then also recognizing that along with those health deficits, things that go wrong with you, there are definite things that will actually improve your health. And that's the wellness plan that we talk about. So things that are health protective, we know a healthy diet and being able to access a healthy diet, socialization, having good quality relationships, exercise at any point in the journey, and caregiver support. Those things are definitely health protective. And then we introduce social prescribing, or the community connector. And this is looking outside of the health system into the community as to connecting seniors to organizations that provide services for seniors, like the community-based senior service resources through United Way, and they're available throughout the province and the rest of Canada, actually, United Way is. And then we've talked to the GPs to refer directly to the community connector, and to introduce a peer coaching program to support seniors to be able to access resources that they can actually use to age more healthily. And the next slide. So the health protective factors I talked about, and then the community connectors is this new program, and it started 3 years ago as a demonstration project, and now it's growing all throughout BC. And I understand that you're getting a community connector here as well, or actually met Jane. Yes? Yes. And so that's really great. And so the GPs that we work with are referring directly to community services like exercise programs or food delivery programs. But the GPs don't really know all that a community has to offer. And these programs can come and go. And in a community like yours, everybody has something to offer. And really that is the beauty of community connections, is that everybody has something to offer to support the seniors. Neighbors can help neighbors. And so that's the whole community connectedness and peer coaching that we want to promote. And the next slide. So social prescribing is a model that we took from the UK, where the healthcare provider actually sees an individual in the office and thinks that they're at risk, so some of those risks for social isolation or health risks, and they'll refer them to a community connector, and in the UK they call them a link worker. And that link worker will do a very thorough intake, might follow them for a number of weeks to try and get to know them, build a relationship, and that link worker is very aware of all the resources in the community and will access and connect the individual. And they'll overcome barriers so that if a person cannot get to a program to do exercise, the connector will find a way to get them there. If there are financial barriers, or if there's other social issues like housing, and these things are really more important than the concern that they talk to their GP about, the connector will address that as well. So that's really being holistic and offering that social support that's going to impact the health of the individual as well. So the next slide. So in Fraser, when we started this demonstration project, working closely with United Way, we developed a program so that referrals can come from GP clinics, they can come from assisted living sites, community health nurses and home health services, as well as hospitals. So if they identify older adults that could benefit from some support in the community, they would get referred to the community connector, who would then connect back to the senior and their caregivers and see what services might be helpful, deal with other social stressors that they might be living with, and then connect them to all of the resources in the community. And the next slide. So this collaboration in Fraser came about through a partnership. So it was really important to develop that partnership between Fraser and United Way and the local divisions of family practice, because then you could identify what needs were between the three parties. And we actually put out an expression of interest to all of the nonprofit organizations, and received some applications from the nonprofit organizations, and then we had to meet the need of the Health Authority and United Way, see whether they've got the structure to actually hire a community connector, manage the position, and the Division of Family Practice wanted to ensure that that organization could work with the GPs in the community, so that this was a collaboration, and we had to score each individual application and to come up with the right organization. So it's a very collaborative process that we developed. And the next slide. And out of that, the demonstration project initially was 19 programs funded across the province. And we in Fraser actually had 10 of those programs because we were a demonstration site. So we were able to really work hard and work to integrate the health system with the community services and expand on the social prescribing scheme. And then because of our work and the evaluation that went on, it was just recently announced that it's going to be expanded, and in the next 2 years we'll have 100 community connectors throughout the province. So really huge successful story and very gratifying. And next slide, please. And along with the Community Connector, there's all these other services that are being provided in the community. And Better at Home, and you guys have one, of course, to provide the light housekeeping, the laundry service, the transportation services, etc., which is so important to help the seniors to age in place. And we work very closely with BC 211. Next slide. Pop up 211, because everybody has to know about 211. And we work with them to actually reorganize all of their directory so that it lines up with your community and with senior services. And so if you want to know where you might find an exercise program for osteoporosis, then they would be able to tell you, because they've reorganized their algorithm. So that's another piece of work that we've done in our collaboration, because 211 is now under United Way also. And the next slide. And because initially we only had 10 community connectors in Fraser and 19 all through BC, we had to really keep the resource of the community connectors for those that are really in need, the ones that really needed that hands-on support. And for the seniors that could access help themselves, or they had family members that could help, they could actually go down the signposting pathway, where they refer to resources like BC 211, and BC 211 has information that they can provide either on their website or by telephone. And so that the community connector can actually really work with those that didn't have the ability to access the website, or even be able to go through a telephone tree to be able to get to the right resource. So the community connector was saved for those really higher needs people, and that's the way it exists for us in Fraser. And the community connector role, again, is seen as the very tip of the iceberg for those seniors that really do need extra help. And the next slide comes from the UK in Hertfordshire, and I visited that site when they were working on this. And so they have this concept, no wrong door. So any senior can actually call, and depending on their complexity, they would get either the signposting at the bottom with some referrals and volunteer groups, etc., to medium support with the community connector. They can do the signposting, but they might need volunteers to help them actually get to what they need. And then the really high needs people for the community navigators, or the link workers, which is our community connectors.
What is signposting?
Signposting is when we give the information rather than connect with them and sort of help to do that hands-on work. So it's for people that can actually navigate the website themselves, or all they need is that information to say, okay, I can go to Park and Rec and attend that Get Up and Go class, and that's all the help that they need, because they can drive themselves, or they can pay for it or whatever. But those that can't drive themselves and they have the financial problems, the community connector needs to intervene more deeply, need to find out where the resources are, where the exercise program is, whether it's even acceptable to the senior to go there, to work with them, improve the motivation so that they would venture to go there. And then if they have problems with finances, then find some resources in the community to help them. So there's a bit of difference there. So the signposting for those that are able, and they just need that direction, and the connector is for those that really need more hands-on in depth. Thank you. Next slide. So, the social prescribing community connector work is to complement traditional medical healthcare system. And there's barriers. When we see socially isolated older adults, they're like that because of some reasons. They might be psychologically that way, or they might have cultural issues that interfere with their ability to connect with their community, financial issues that we talked about, or physical. They just can't get to those places. And the connector then really works with what matters most, what really is important for that individual, and how can we cross those barriers, the financial, the cultural, the physical, the psychological. And we have connectors that work with older adults who have real problems with hoarding. Nobody can go into their home. Home health nurses cannot get in there to do any help. And so the connector will work with the older adult to see, can we get some help to be able to clear this path so that the nurse can come in to help you. So this is the hands-on work that actually gets done on the ground, which is really tremendous. And then really trying to motivate the individual by asking what more matters most. And a lot of times, as I really don't want to walk with this walker anymore. It's really gets in the way. I can't get onto the public transit or whatever. And so then the connector might work with the health system to see if we can bring in some occupational therapist or physiotherapist and connect to the healthcare system to help the individual to get the most out of their lives. And then in Fraser, we've set up the referral pathways to actually access the community connector. So from home health offices, our community health nurses and home support workers can make the referral. The primary care providers, our nurse practitioners, our GPs, assisted living sites, community health nurses from assisted living sites, when they actually see seniors that are living there and are isolated, they'll make the referral. And we've actually connected with hospitals and pre-op departments. And they were really thrilled to see this because they receive patients for hip replacement surgeries, knee replacement surgeries, and they used to function not too bad, but with a big problem, but they're coming in for surgery. And after surgery, they'll have a period of about 4 to 6 weeks they're actually going to be dependent. And for a short period of time, they really need connection to resources in the community. They need help with meal preparation during that time because they can't get anywhere to get the food, to be able to cook for themselves, all of those things. And I've had patients come in during the flu season where they have nobody to call. And that's my one question is, do you have anybody to call? Because you really need chicken soup. You've got flu, you need to get hydrated. Who's going to get the juice for you from the grocery store? And some people just have no one to call. And so the pre-op department were really thrilled that they could actually offer connection to the community connector for the date of their operation, and when they're expected to be discharged back home, then they've got a connection to the community to be able to access those resources in the community. And then acute care now, when patients are admitted, a lot of our older adults will get admitted to hospital because of a medical reason. They might have a heart problem or they might have falls, and they decline in hospital. If they're in hospital for more than 7 days, they've lost a lot of their muscle function. They can't really walk the way they used to. They've lost their community connections. And so we do have a lot of seniors that stay in hospital for more than 30 days. Some 6 weeks, 12 weeks they've been in hospital. Their home is not safe for them to get home. And during that time, they just decline. And so the acute care discharging process is not just about their medical situation, but it's really about their social supports. Who's going to pick up their medication? Who's actually going to, pick up the dog that's at their friend's house? All these things that are really important to the older adult. But the medical people don't talk about that because they're just interested in the hip is fixed and she can go home. She can walk up the stairs, that kind of thing. And so a patient-directed discharge process is what we're working on in Fraser now. And so connecting from acute care to those community services is really helpful. And the next slide. And alongside, we have a lot of work going on for self-management, for people to really look at their lifestyles and try and delay frailty for as long as possible, or reverse frailty. So AVOID is the acronym. A is for activity, and we know that exercise at any point in your frailty journey or aging journey is important. Exercise is so helpful for brain health, for cognitive decline. So we encourage that and find the right exercise program in the community, and it may be just the walking club, or it might be just going to an osteofit class or something like that. V is for vaccines. I heard that mentioned as a topic for future. And for seniors, it's really important to get the vaccination because their immune system is not as robust as it used to be. So we always talk about the top 3, the flu vaccine, the pneumonia vaccine, the COVID vaccine, and I always add the shingles vaccine. Those 4 are so critically important because shingles will take you down if you're immune compromised, or if you're living alone and you can't get the right services. It can be really hard. So avoiding disease is what B is all about, the vaccine. O is for optimizing your medication, and that's about asking whether that medication is still necessary for you. Is the dose still the right dose? Maybe you've lost weight over time, and having a pharmacist or your family doctor look at your list of medications on a yearly basis is so important, because drugs will interact, and a lot of people will take things over the counter, and some older adults will be seeing different doctors, and they'll have a whole bunch of different drugs, and one doctor may not know of all the others that they're on. And so having that comprehensive review of all the meds is really important. And then I is for social interaction, all about social interaction and avoiding loneliness that I covered earlier. And then D is about diet, food security, ensuring that older adults have food available to them that's of high value, and thinking about food as medicine, and ensuring that you have enough protein intake and calcium and vitamin D supplements if appropriate. So all of those things are self-management tools. If you have the ability to do these things yourself, greater chance that you're not going to become frail anytime soon. You're going to be able to reduce frailty, delay frailty, and that's the message with the AVOID framework from Canadian Frailty Network. And the next slide. So in a study that we did, and that was part of this as well a number of years ago, we had an intervention, a 6-month intervention where a coach would call an older adult, talk about in getting involved in a social and exercise program, and they would support them with weekly calls. And they did this over a period of 6 months. And we actually saw a 30% increase in walking independently from beginning to end of 6 months, 60% increase in exercise frequency, 59% increase in health attitude and their feeling of wellness, and 11% increase in social engagement. And we measured the frailty index that I talked about earlier before and after that 6-month period of coaching. And there was a 3% reduction in frailty. So you can actually make a difference. So a frailty score of 0.03 reduction is significant because it goes from 0 to 1, the frailty index. 0, where you're not frail at all, you're fit. 0.25, you're frail. And then when you get to 0.5, you're starting to become end of life. And 0.7 is not compatible with life. So when you have a reduction of 0.03, that's pretty significant. And the next slide. So the AVOID Frailty is a really important program that we're trying to spread throughout the province. And BC Self-Management is a program that's been in existence for a number of years. And they've just recently developed an AVOID Frailty module to add to their other modules that they have on chronic diseases and pain management. And this is now going to receive ongoing funding. So anybody can get free telephone peer coaching over a period of about 12 weeks, using the AVOID action plan to be able to set goals. And this has been shown to reduce the frailty score over a 5-month pilot that we ran over the last 1 year. So this telephone peer coaching program might be something to think about for yourself and for older adults in your lives. And the next slide. So then how do we avoid frailty and increase the health span? So as you know, we're living longer in Canada, but for the last 10 years, 8 to 10 years of older adults' lives, people are living with frailty. So the whole thing we need to do is reduce the frailty at the end of life, reduce the suffering with frailty, and increase that health span. And, you know, it could be we live a longer lifespan, but we want to live longer and suffer. We want the health span. And so that's what the call to action is about. And that's where I think the community and health service integration and talking about how can we step up to help older adults together is going to actually lead to better outcomes and opportunity for healthy aging. And to support self-management, if we can do that with programs like peer coaching, if we can do self-management by offering resources in the community through signposting, all of that's going to help. And it does take a village to age well. And so walking clubs and garden clubs have been shown to benefit people and their aging outcomes. And Men's Shed, have you heard of Men's Shed? Mm-hmm. No, this is a program that came out of Australia, and United Way is now offering Men's Sheds and grants for men to actually open up the garages with woodworking tools. If they have a woodworking tool, they can actually get a grant and invite other people to come over to start building things together. And in building things together, they'll chit-chat about this and that, and they'll get on to other topics as well. And they'll actually start socializing and making friends. Can you imagine that for our men? That would be fantastic, right? Because it's really hard to get our men to join clubs, right? So anyway, a lot of you saw Blue Zone, Living to 100 on Netflix. And the thing I got out of that is that they didn't set out to live longer, the people that live in these blue zones. They live longer because of their lifestyles. They actually have to walk up a hill to be able to visit their mother or visit their sister. And that lifestyle is actually conducive to staying healthy. And 100 years olds are out there volunteering and helping others people and doing sing-alongs and crocheting and whatever they need to do. So really is the lifestyle that we want to embed that's going to allow us to do healthy aging. And the next slide. So you probably have something like this. This is a nonprofit organization in my community. It's called Seniors Come Share. Now it's called Brella actually. But they have a community support program. So they have volunteers and they have activities that people can drop in and participate in. They have a Better at Home program there as well, and they also have a Community Connector program, and that's expanding. They're getting another Community Connector, and they have a day program. And so all these activities run by staff from the organization as well as volunteers to encourage socialization and activities, and Health Authority partnership, because we have nurses there as well that will take their blood pressure, ensure that they get their blood sugars checked if they're diabetic, and so that health integration with community support is what the day program is all about there. And next slide, we're getting close to the end. So at a systems level, I've been trying to implement this frailty prevention pathway, and I was lucky, I think I was positioned well to be able to have a bit of influence with the executive, consider this to be an organizational goal for this last year. So on the outside, the orange rim are the frailty scale that I talked about. So you can start with healthy, and then pre-frail, mild frail, moderate frail, and severely frail. And depending on where you are in the frailty spectrum, you might be living at home, or you might be living in an independent assisted living facility, or you might be at home receiving ongoing home care, or at end of life you might be receiving palliative services, etc. And then in the center is the AVOID strategy that everybody has to talk about. So all our staff are taking education on the AVOID strategy. And whenever they encounter with an older adult, they'll be talking about, have you had your vaccinations this year? Do you eat fruits and vegetables? How many times are you exercising? How many times are you seeing your family? So this is just part of their conversation all the time, that AVOID strategy. And then right along the bottom are the resources to be able to refer patients to, older adults to, depending on their frailty level. And if they're light blue and they're pre-frail, then they're going to community connectors maybe, or they're going to Quack and Rec for their exercise programming. If they're in the middle with a light darker blue, they might need some help at home from home support or caregiver support. And then when they're at the right end, they might need more nursing care and home care nurses and allied health, etc. So we have this being implemented in Fraser Health, which is really gratifying to see. And we're starting to work with communities' primary care networks to be able to embed this in the work that they do with their older adults. And next slide. This is another systems framework that I found really interesting. It's in the States. It's called Age-Friendly Health Systems, and you can just look that up and you can build a system around that. And it starts with the question, the 4 M's. What matters? So, you know, what is important in an older adult's life? What goals of care do they want at end of life as they become unwell? Starting to think about what they want as they get older, what kind of medical interventions they might want. That kind of discussion needs to take place. Next M is medication. And again, asking what matters to the individual will lead to how many drugs are important that the person takes, and having that optimized in their medication, as we have also in the AVOID strategy. Meditation is to prevent and treat and manage dementia and depression and delirium, and really looking at cognitive health and ensuring that people get whatever they need to be able to optimize their interactions and optimize their ability to maintain their memory as they get older. And mobility, and ensure that the older adults are moving every day, if they're able to get them to exercise every day. And the 4 M's then has been implemented in many different health systems in the United States, and they're well supported by the Institute of Healthcare Improvement in the States. And next slide. And I don't know why that's there, and the next slide after that. And this is the last bit that I'm going to leave you with. And this is something that we've been working on over the last year with a grant from the Canadian Frailty Network. And it's a website, pacifichealthyaging.ca. And it's a website that has information for older adults with some common health topics like incontinence, depression, frailty, There's about 13 different topics, and we just added another topic on health, our hearing, and what you can do about your hearing as you get older. And it's not just about hearing aids, but there are other things that you can do, and why you might want to speak to an audiologist. So that's information that's going on, that has been going on just recently. And then along with that, you have this little yellow button over to the right. You can take a healthy aging assessment. And by doing that, you'll get a report of your assessment of where you're at in terms of your healthy aging journey, and what sort of supports and resources might be helpful for you. And it'll give you a map of where you might find these resources. And so anywhere in BC, according to BC 211, it will tell you where you can go for exercise program, where you might be able to get meals delivered, that kind of thing. Next slide. And on the same website, there you go with the healthy aging assessment tool. And once you've registered with the assessment there, they'll send you email prompts over time to say, hey, this is going on, and you might want to listen to this webinar. So there's ongoing information and connection with that website. And the next slide. So then in conclusion, I talked about intrinsic capacity. And I hope that you got some ideas of how you can improve your intrinsic capacity and continue to look for ways to improve your intrinsic capacity. That's your physical and mental wellness that's going to hold you as you get older. And the functional capacity, that's the interaction with your community. And I think your community is fantastic, and you're well on your way to supporting healthy aging. So it's not just about the social capital, which is looking at all of the assets in your community. That's great, you need to do that as well. But it has to have social cohesion, where you have to have mutual community trust and solidarity, where you're building shared values and communities to reduce disparities. And that social cohesion is something that is so important to build, where you understand why you're doing what you're doing for your neighbor. And I'm going to stop at that, I think. Thank you so much for your attention. Talk really fast, but I'm happy to answer any questions.
Thank you, Dr. Park. Now, are there any questions for Dr. Park about the presentation, or healthy aging, or frailty prevention? Peter?
So, Grace, I'd like to hear a little more about this position, the community connector. I mean, it sounds sort of like a social worker. And how does it differ from social worker? And what are the training requirements of somebody like that? Are there people out there you can hire as community connectors? Or?
Yeah, so we have a job description that we've created, and really there's no professional kind of training that's required, but many of those that apply for the positions are retired healthcare workers. It just happened to be that way. But foremost, they have to know their community and all of the services available, so that's number one. And number two, they have to be passionate about wanting to help seniors in the community and be able to communicate well and interact with other sectors. And so those are some of the key features in their application that we look for. So there's no specific requirement. And social workers, we have some that actually apply that are social workers, but they don't have to be. And the social workers that we have that work for the Health Authority will deal with very legal things like AGM, AGA kind of requirements, and legal things when it comes to neglect and abuse, that kind of thing. But the community connectors tend to just get to know the individual and find out where they're at, what sorts of things are barriers for them in accessing care, accessing connection to their community. So it's more of a, if you had a really caring, knowledgeable daughter, that's what I think would be a great community connection. Daughter who's really available.
And I just have to jump in and introduce this group to Jane Harrison, who is our community connector, and is all of those things. She is our Jane. Would you please stand? And I don't think it's fair for us to put Jane on the spot unless she wants to come forward and talk a little bit about what's going to happen for our community. But we're thrilled that Jane is going to be our community connector, and has already met with Dr. Park, and we're hoping that future. But Jane, if you did want to speak anything about what's happening. would you be up to that, or?
Sure.
Come on
So-
up. She is that caring daughter we all love, so come on up.
God knows, you just help set up the microphone.
You should know better.
So for our community, the Community Connector, because we already have a Better at Home program in place and we have a relationship with the United Way of BC, the Community Connector is actually a shared position for actually all the Southern Gulf Islands. So between Salt Spring, Saturna, Galliano, and ourselves. Unfortunately, Maine doesn't have a Community Connector yet. So we have just over a 1.2 or 3 FTE that's shared between the islands. So for us, it's going to be a 2-day position, and it's something that we're just building. The funding actually hasn't come through yet, but we're told next week, April 1st. So our plan is to spend the summer organizing ourselves, coming up with some sort of base documents that we'll be using and some of these scales that we'll be applying, and with hopes that we'll be up and running in September. That's our plan. Yeah. And so it will be open to any older adult. You don't have to be a Better at Home client. We'll probably start with some of our Better at Home clients because we know those needs. But yeah, it's something that will be kind of hopefully a natural progression as we go along and learn.
Thanks, Jane.
Yeah.
Are there any other questions for Dr. Park? Yeah. Oh, I'll take the lady in the back. And
When you first started talking about socializing, I thought we were going to have to start planning parties. That's not my question, though. My question is, does the Community Connector exist on Vancouver Island in any communities right now?
you can look. Yes, it does.
Yes, it does, and there is quite a group out of Victoria looking at social prescribing, and so they're moving forward. With the expansion with United Way, we've gone from 19 in the province to 100 in the next 2 years, and so it's going to be everywhere. And so it's up to the organizations to keep following United Way's call for proposals and call for applications. So definitely. But planning parties is a really great idea.
Linda, did you have a question?
Yeah, thank you. I was interested, Grace, in knowing more about how the peer coaching aspect worked. Is it like a call center? Is it volunteers?
So BC Self-Management is a program that's been in existence for about 20 years, led by Patrick McGowan out of University of Victoria. And you can just go online and look at Self-Management BC, and they just added the AVOID Frailty module. So their pain module is very, very popular. And the leaders of these groups, their group kind of education sessions, are volunteers that have suffered usually on their own from the condition that they're talking about. And they go through quite a rigorous training program with self-management that comes out of Stanford, I think. And so these volunteers are trained to connect with the people that are signed up for the program. And so the peer coaching for frailty has all been on by telephone. And so they get a telephone once a week, and they're followed for 12 to 13 weeks. And they set goals around the AVOID strategy. So if they don't go out and don't exercise, they really talk about what is it that interests you, what sorts of things might be acceptable, and how can we get you there. And they set small goals that are achievable, and then follow up next week to see if they made it, and if they didn't, then what got in their way. So that real breakdown of setting of the SMART goals, that's what they do best. Yeah.
Thank you.
And I just want to comment, because also it's really our intention to leave you with hope here. So we here on Pender have recently made an application for a grant. Peter, thank you, Dr. Peter Perry has written it, for a health navigator position. So that position, what you saw on these slides, there's a series of wonderful organizations that you can get more information from if you know all these online sites, right? So we are hoping to get a person who will work with Jane and her team, but will span the lifespan from children to older adults, and help people navigate how to find the resources online or in the community that can support them and their families. So you might have an older parent who is ill, but you also have kids who might have substance use, or you yourself are worrying about depression. So that position is something we really hope to have this summer, and that would be for a 1-year pilot. So we're really trying to take the evidence that we see researchers and leaders like Dr. Park and her team, and we're trying to implement that here on Pender. So fingers crossed. Any other questions for Dr. Park? Yes.
Yeah, on one of your slides, maybe more than one, there was a place that you could click on a yellow button that would take you to a self-assessment. So even though this is Fraser Health, we could go to that website and just, it'd be interesting to know where, for example, where I am and where my
Yes,
wife is in terms of the
absolutely. Oh,
risks.
thank you for that question. I'd love to talk more about that button. It's not Fraser Health. That website is not Fraser Health. It was actually a collaboration all throughout BC with 5 universities and all 5 health authorities. So the button actually takes you to a site in Ontario, the Canadian Frailty Network. And so anybody across the country can sign on, and through that portal you can actually go, so look at the Pacific Center for Healthy Aging site and look at all of the information there. But by clicking on that yellow button, it'll take you to the CFN website portal, and then there you sign on. You do have to sign on, yeah, and then that's how you get the assessment done. And then you're on their list to email you prompts from time to time to say, okay, you need to do this and that, and there's a new talk coming from the Canadian Frailty Network by a geriatrician. If you want to attend, click here. So that connects you. And so yes, anybody, even though you're not Fraser Health, definitely.
Thank you.
Yes.
I just like to ask, with regards to the community connectors, is the commitment from the provincial government to keep supporting these, and how long is that for, the ongoing support? And then once issues are identified with the clients, are the connections to their family physicians or healthcare providers that will support the people that are working in that environment?
Thank you. Yeah, so the demonstration project started in 2019 or 2018, somewhere in there. So it was 3 years long. And then after that, there was an evaluation. And that was when the government was going to decide whether it was going to be ongoing funding. So Better at Home started as a similar demonstration project back in 2015, I think. And then it showed a benefit to older adults living at home. There's a huge need to support seniors living at home. So the government is saying they're going to provide us with ongoing funding. So as far as we know, it's going to be like Better at Home. It's going to be an expansion of what's offered through Better at Home. Community connectors are going to be here to stay. And the social prescribing scheme that started out in the UK, it's caught on practically everywhere around the world. Big center in Singapore, big center in Australia. And Canada now has a center for Canadian Institute of Social Prescribing that's run by Canadian Red Cross. And there's a real academic support to that out of the Dalai Lama School of Public Health. There's a PhD program. So it's really taking off as a country. So I think it's going to be firmly embedded in the fabric of life in Canada. That's my hope. As I retire, that better happen. And so yes, I think that we can hope, and I think we're optimistic that it's going to be continued funding from the Ministry of Health. And the question about connecting back to the family doctor. So we meet as a community of practice with the community connectors regularly. And we answer their queries and concerns about the kinds of referrals that they're getting from the health sector in particular. And we have heard from the GPs that they really want to know when they send a referral to a community connector that the connector is going to call up their patient. And so we're working through that process now to try and make it happen as easily as possible, not take up a lot of the time for the connector, but for the GP to at least get some acknowledgement that the referral has been received. So we're working on that for sure. Great questions. Anybody else? Yes.
I'm concerned about the increase. Well, Fraser, I don't know what the status is for Fraser Health, but Island Health is privatizing more and more of the services. Not so much on Pender, but in the Saanich Peninsula. My father was dealing with that. And when I dealt with people from Island Health, it was really excellent. But they have privatized many of their services,
Mhm.
and there were big holes there.
Mhm.
So it would be good if we continued to fund things and not privatize.
Mhm. Yeah, we went through that in Fraser as well, where the home support was privatized and we had agencies in the community providing that care. And it was really difficult because you can't really standardize practice, and they had their own reporting elements and structure because of their private nature. And then after a number of years, we decided to stop that, and we actually repatriated everything back into Fraser. And so now we work very closely with the home support providers every day that go and see older adults. They have an LPN that they can call if they see a health concern. They are educated on the AVOID strategy because we want them to know about AVOID. So we can actually work with the home support staff. So I agree, having a public system I think would be helpful. They'll probably come around. You know, all these things come around. They have to go through the pain, and then they have to decide, okay, got to go through the pain of reverting back. It's a lot of work to revert back.
Well, and so it's done kind of almost below the surface. You don't realize it's
Yeah.
done.
Yeah.
Like Rebalance is private, and I had experience with it. It's very good. But the home health,
Mhm.
the home support,
Yeah.
very often was didn't show up. There was no.
Yeah.
There was somebody different every time.
Yeah.
That sort of thing. So that's
Yeah,
a real.
I think they start off with the intention of trying to provide more services because they think that it's going to be more, you know, cost efficient or something, but then they realize it's not good quality. And so if you have the energy to make complaints, please do. That's what we've got here is complaints from the users to be able to get the funders to recognize that that was not a good move.
So the Better at Home is through the ministry?
Better at Home is through the ministry, but it's a different stream. So it comes through United Way. So that's considered a community funding stream. So it's different from the health funding stream. So home health and home support all gets funded through the health stream, but United Way and Community Connectors now coming through United Way as a community stream. So it's a little bit different.
So I'm sorry, I'm asking too many questions.
No, it's okay.
Okay, so the United Way, what is their relationship with private health?
They don't have a relationship with private health.
So they're with the ministry?
They're a community nonprofit organization, so they're not really even with the ministry. They're represented by the community-based community-based senior services, and they have a position with the ministry at the table, and so they're interacting with health ministry all the time. But United Way itself really is an affiliation of all the nonprofit organizations in the province, so they're not really related to health, except I stepped in there, I said, hey, we've got to connect. And so we've connected with health and community, but they don't connect with health on their own, per se. Anybody else?
Grace, you said vaccines, and you said shingle.
Yes.
Is shingles now free?
It's going to be probably in the next few years. I think that's what I heard, but right now it's not.
So you're recommending it, but it's still not on the.
It's not covered by
Not
the.
covered.
No.
So
Yeah.
how many people have had their shingles vaccine?
Very good. That's really good. Yeah. Yeah, it's worth paying for because it really does take you out. It's very nasty.
What about RSV vaccine? Is that?
RSV vaccine is still not covered, and yeah, but it is available. But certainly for people that have any lung issues, it's a really good idea to get it. Yeah.
So you can go to the pharmacy and get it? Or?
Mhm. Usually you need to, I think if you talk to your specialty doctor first about vaccines in general. And then we have people that are, immune compromised that recently got through cancer treatment, or people that have, ongoing immune problems. They need to get covered for a lot of things, like even meningococcus would be a good thing for people that don't have spleens, and there's a whole lot of them. And so the more vaccines, the better. This is what my public health colleagues say. You just want to prevent disease, so just get vaccinated up. Yes.
What route would you go if you don't have a family doctor? Like, can you go to the pharmacy and say, I'd like to get a measles update or can they provide that?
Yes, they can, and certainly with recent worries about the measles cases that are coming out, they're worried about increasing numbers. The pharmacists do have that information and they do have that available. And I think it's a funded program, and so you can go and get that vaccine. And the pharmacists are really a great resource for vaccines because they follow the letter of the law and just tell you exactly whether you should be getting it or whether you shouldn't, and the sequence of it, should get the vaccines together or separate them. All of those things. The pharmacists are really great. Yes, I saw a hand over there, yes.
I just wanted to clarify one thing on Pender. So I'm not sure our local pharmacy does have the measles vaccine, but it's available through public health, so you can make an appointment with a public health nurse who comes to Pender in a couple of weeks to get any publicly funded vaccines through her. Yeah.
And then that's the medical center?
We don't book her appointments, but we can get you the phone number to book. Yeah. So she comes over from the peninsula. So the pharmacy was carrying some vaccines. They carried, I think, some COVID vaccines and the flu vaccines seasonally, but I don't know that they keep a stock of all the publicly funded vaccines. Just local knowledge.
Thank you.
That's why you're the community connector.
You just did the signposting thing.
You just did the subject. Okay. Well, so I think we're over an hour, so.
That's great, thank you guys.
Yeah, so I just want to thank Dr. Park for, making the big trip through the Salish Sea and over to the lovely, or I say through the portal to Penderland, where all good things happen. But thank you very much, Dr. Park. And thank you for coming today, and please be careful going down the stairs.